All right, so I think I've stalled this for long enough. We can continue now with NBME 21 explanations. We were done with the first 40 questions, so um, as usual, remember that any of these explanations I usually reference back to my personal annotated version of the first aid. Everything here is purchasable, so you can just shoot me an email if you're looking to buy any of it. And if you do need to ask a question about anything I explain, make sure you always reference to the question number by using the number at the bottom. So for example, this is question number 41, not 44, right? So 44 is just the number that they put for the question, but this is actually question number 41 for us. This question itself actually was quite interesting. Very difficult one for many, mostly because of the intimidating factor of not really understanding NMDA receptors very well, right? So we can just get right to it. So this first question right here says, during an experiment, an investigator observes that glutamate depolarizes cells through both NMDA and non-NMDA receptors. So at this point, things that would help you would be knowing how glutamate works, what is the purpose of glutamate, and then of course if you know what NMDA is about, then that helps too. She finds that the initial depolarization phase of a glutamate-induced fast excitatory postsynaptic potential is generally mediated by activation of non-NMDA type glutamate receptors rather than NMDA type glutamate receptors. Which of the following best explains this finding? Right? Now, the question asks you to explain the finding, but if you have no idea what this finding is even about, then you're very much intimidated and lost. And at this point, you're at the verge of maybe reading the question one more time to see if you can catch something, and then look at the answer choices to see if you can figure something out and cancel something out. Maybe simply because one of the answer choices might not even be a true statement. So you gotta figure out what's happening. So they told you that the initial depolarization, right, of the glutamate-induced excitatory. So they helped you out a little bit. They told you that glutamate is excitatory. Excitatory postsynaptic, so this is after the synapse, potential is generally mediated by activation of a non-NMDA type glutamate receptor. So now you got to think of receptors that you know about. Right, so here the answer was A. NMDA receptors are blocked by magnesium at the resting membrane potential. And why would you pick this? So this one was tricky, but you could have gotten this without much knowledge of NMDA receptors. The stem told you glutamate activates both non-NMDA and NMDA receptors, but here in she finds in her findings it activated only non-NMDA receptors in the early phase. This means NMDA receptors activate after non-NMDA receptors, right? That has to be the only explanation. Right? So that kind of deduction comes from truly just getting English and not trying to have some kind of backwards knowledge, right? What we often try to do with questions is we try to tap into a knowledge base of another previous question we might have done that was similar to this, rather than just facing the question mathematically and logically. So they told you that glutamate will activate both NMDA and then the non-NMDA, right? Both things have to be activated. And then they tell you that initially it only activated this one, the non-NMDA. That means that this must activate first and then this will activate later, right? That's the only explanation. Obviously, the NMDA receptor must not be activating first, because if it was activating first, it would be there in the initial. At that point, the non-NMDA would activate later. So that means the NMDA receptors activate after the non-NMDA ones. Therefore, something was delaying NMDA receptor activation, and the only answer that says something about that is A. Right? B says NMDA receptors are more permeable to calcium, and C says NMDA receptors can be activated only if the cell membrane is hyperpolarized. Hyperpolarization is almost never necessary to activate something. You just need a depolarization, right? Hyperpolarized would be the opposite way, so that's not going to make sense. And then the other answer choices for this are also just wrong. None of these answer choices besides A tell you that NMDA is going to activate later. That's all you needed for the answer here. So although, very much depicted as a difficult looking question, it wasn't. You just have to keep your calm and just read what's happening. Both receptors must activate. In the initial phase, only the non-activated. That means that the actual NMDA receptor will be activating later on. And the only answer choice that tells you that it must be, blocked in the beginning is A. Okay, so not the worst thing on earth. First aid doesn't really talk about it much. in terms of receptors, let me see. Where are receptors even mainly discussed? I think right in autonomic drugs. So they talk about a couple of receptors right here, right? The acetylcholine receptors, nicotinic versus muscarinic, and that's really all there is to it. So NMDA receptors are not exactly a major discussion in first aid either, which is another reason that you would get intimidated, because you'll be like, I haven't really read much about NMDA receptors. You didn't need to know anything about NMDA receptors to answer this question. That's it. Next question says, so 42, 55-year-old African-American man with hypertension is asked by the public relations representative of a hospital if he will allow filming of his next visit with the physician for a future broadcast designed to raise public awareness of hypertension. After full disclosure of the plan, the patient consents to filming and broadcasting. Immediately after filming is completed, the patient tells the physician that he does not want his medical condition made public. Which of the following is the most appropriate response by the physician? So consenting is a big part of my new job too, right? Where we do clinical trials. You can consent, and you have to consent for the clinical trial or anything within a medical field to be done. Without your permission as a patient, nothing can be done. Now, this man, 55-year-old African-American man, agreed after the full disclosure, agreed to give his consent for this video, this filming to occur. And maybe afterwards he felt like the film came out a little embarrassing or made him look bad, or maybe he felt some shame, whatever the reason might be. No one needs a reason. He can withdraw consent at any time. Part of consenting is telling your patient, telling the person that they can withdraw consent at any time. That's part of consenting, right? Never in consenting do you ever say, once you say you give us permission, it's written in stone and it will be done. That never occurs, right? So if this patient doesn't want it, then D, right? Tell the patient that he can change his mind about participating. That's it. You can change your mind. There's nothing against that, right? Consenting would be really scary and would rather become like a law or like commanding rather than consenting if you couldn't take back what you said, right? You can't take back what you said. So that doesn't happen, right? And I wrote some of the basic things that came from like a Reddit user, but there's a bunch of basics I always talk about with ethics questions. You never want to be rude. You never want to say something that can even remotely be taken as condescending, insulting, rude, negative, blah, blah, any of these things. You're always treating everyone the nicest and best you possibly can, as if you owe them a lot and that they are basically the only reason you're alive, right? They're the king of the world and you got to be nice to them. So very, very important to watch for stuff like that. But overall, this was a really easy question. Just another way to ask about consenting. Consenting is a very big deal in American medicine. 44-year-old man comes to the physician because of increasingly severe pain and swelling of his knuckles and knees during the past month. Physical exam shows tenderness, swelling, and warmth of the involved joints. Lab studies show an increased erythrocyte sedimentation rate and serum rheumatoid factor. So ESR, erythrocyte sedimentation rate, is just a sign of inflammation. The patient improves clinically after treatment with ibuprofen for 2 weeks. Which of the following sets of findings in plasma is most likely after 2 weeks of this therapy? Right, so they're giving him just that. All right, so they treated him with ibuprofen for 2 weeks. Now you got to know how ibuprofen works. Right, it's related to the arachidonic pathway, and then you look at all your answer choices. These are all things from that one pharmacology page. And the only answer choice here that would work would be B, right? You're blocking off a COX enzyme. Ibuprofen is a COX inhibitor. Let's take a look at that real quick. Right, from this page that not only helps you understand all of that, but also teaches you a lot about NSAID exacerbated respiratory disease or aspirin-induced asthma. Right, all of that stuff is also explained based off of this page. So ibuprofen, as you can see right here, is one of your NSAIDs, right? And it is an inhibitor of both enzymes. So if you just block off this entire pathway on this side, right, you just turn this entire stuff off, you're not going to make any of these things, no more of these things. And how much of these guys you make is what determines NSAID-induced asthma, actually. If for some reason, because you're not making this, you start making more of these guys, you're going to make more of these guys, right? And these guys increase bronchial tone, which is asthma, okay? Okay, so that's NSAID-induced asthma. But here the answer is B, right? So leukotriene C4 increased, arachidonic acid increased, prostaglandins of any kind decreased, right? That's the first thing you would look at to cancel out answer choices. Anywhere it says that you're making more prostaglandins would be the wrong answer choice, because NSAIDs are there to stop making prostaglandins. NSAIDs get rid of prostaglandins, right? And then you would make more of the C4 and any other leukotriene for that matter, and you would have more arachidonic acid also, right? You would have more arachidonic acid because arachidonic acid was being shunted this way as well as this way. Now you're not shunting it in this way, so a lot more of it is safe, right? And eventually you're going to start shunting double in this way. And if you do that, if this patient does do that, then they're going to end up having NSAID-induced asthma, which is kind of what they're describing, because they're saying he's going to make more C4, all right? So that's the basic concept of NSAID-induced asthma or aspirin-induced asthma, any of that stuff. But nothing crazy here. And so I wrote that here too. This is the basis of NERD, NSAID-exacerbated respiratory disease. Number 44, an 8-year-old girl is brought to the physician for a well child examination. Her mother says that she has been well except for an occasional cold. Her immunizations are up to date. She's at the 50th percentile for height and 60th percentile for weight. Physical exam shows breast bud development and a few pubic hairs. The mother asks whether her daughter's development is normal. Which of the following is the most appropriate initial response by the physician? Well, nothing in this question was mentioned to be that bad, right? NBME loves asking questions like this, and they really hope and pray that these percentiles, 50th and 60th, will make you think it's bad, right? That those are pretty bad percentages. I won't argue that. You don't want to get a 50 or a 60 on any test. Alright, but it's very important to understand that as far as percentiles for development and stuff like this are concerned, unless it's below 25%, you really don't want to consider it. Alright, everyone grows differently, everyone matures differently, everyone has a different growth speed and metabolism and so on and so on. So it's really not a deal, right? It's not that big of a deal. If at 8 years old she's only reached 50th percentile for height and 60th percentile for weight, that's okay. Right, because she is still growing. Nothing else is wrong. If she didn't have any breast bud development, or if she had excessive pubic hairs, then you could maybe think something's wrong, right? But there's just no reason for you to think anything's wrong in this question stem at all, and you would just put E. Your daughter's development is normal. But you have to be careful though. This is almost always an answer choice, so that doesn't mean that anytime you see it, you do pick it. You should check if something's wrong, and if any of these percentiles are way too low or way too high, right, where not exactly way too high, but more so like if they tell you everything's too far ahead of her time, she might have precocious puberty, right? But this is not precocious puberty. This is not precocious puberty. Now, the Tanner stages are not exactly the best thing on earth, and they're really easy to abuse in questions. You can make questions very difficult by just tossing in Tanner stage development. You got to make sure you know what's happening, right? The normal Tanner stages of development, which are described here, and the fact that you can be in two different Tanner stages for different things, right? And then also understanding how questions present. So very important to know, right? You can't pick an answer where someone is saying something's wrong with their Tanner stage development if it isn't just blatantly obvious. It has to be like something super obvious. And so these age gaps that are here, these do help. They definitely help. And our patient in that question was 8, right? She's at the beginning of this stage right here, and she's pretty much normal. Right? Nothing crazy there. Let's get rid of this. All right, next one here. Okay, this was very intimidating. Right, very intimidating for a lot of pretty much every. I liked this question because they used this graph to test you on basically pharmacology. Right, it's very rare. NBME doesn't really test much on the pharmacology chapter, nor much on the biochem metabolism chapter. Those things are very rare on NBME. They used this graph to try to get you to tap into your knowledge of KM and Vmax, right? And I love this question, so I actually ended up saving this question as a separate slide in one of my PDFs I use with students to kind of gauge their understanding, right? Because this question does a great job gauging your understanding of KM and Vmax and math in general. So a 5-year-old boy who has homocystinuria improves with high-dose oral pyridoxine therapy, and that's normal. that is a therapy, cystathionine synthase activity is 95% deficient in his cultured fibroblasts, but activity increases to normal after the fibroblasts are incubated with higher concentrations of pyridoxal phosphate. When cystathionine synthase activity is measured in the presence of pyridoxal phosphate, which of the following Lineweaver-Burk plots would be most consistent with this patient's findings compared with the kinetics of the enzyme in a normal individual? Right, so they gave you the kinetics of a normal individual, and then they want to know what's going to be the thing for this guy, right? Which of the following would be most consistent with his kinetics compared to a normal in the presence of pyridoxal phosphate, all right? So pyridoxal phosphate is making his stuff work. Now you look at the graphs. There's A and B, and there's C and D, and you have to go back and recall from pharmacology how that graph works, right? What is the point of the Lineweaver-Burk plot? What does it tell you? What is it graphing for you? What are all the points on this? Now they did label it for you, right? They told you over here is 1 over pyridoxal phosphate, and over here is 1 over cystathionine synthase activity, right? So enzyme activity, and that's the substrate. And these are inverses because that's how Lineweaver-Burk plots are made, right? Normally this is the graph, but if you take the inverse of this graph, then you can make a straight line, and that's why we like Lineweaver-Burk plots, because it's a straight line. So you can see from here that the y-axis is your v, or 1 over v, and the x-axis tells you about your km, or negative 1 over km, negative because it's on the left side of the y-axis. So looking at this, right, you can tell that there's a couple things about which ones are competitive and non-competitive, and thankfully our question isn't about that. Our question is not about competitive versus non-competitive inhibitors. Right, so let's read what I wrote here. The question states that giving B6 increases the activity to normal levels, which means the activity should be the same as the normal. Hence, their y-intercept should be the same. Right, and that much was very obvious, and they did put the words into the question. Right, and in the graph. So this is activity, which is related to your y-axis. So the activity needs to be the same as the normal, and the only ones with the same y-intercept are all of these guys here. Right, so normal, B, and C. So you can already cancel out D and A as possible answer choices. Right, A's activity is all the way up here, and D's activity is all the way down here. And since these are inverses, you kind of want to think that D has the fastest activity, whereas A has the slowest activity, right? So that's one thing. And now that we've knocked out A and D as answer choices, and we know that the activity has to be the same, we're now down to picking between B or C. So that their difference is based off of these points over here. And so this one here for the pyridoxal phosphate substrate, or this one here. Which one are we going to pick, right? Now, we're adding pyridoxal phosphate. We're increasing the amount of pyridoxal phosphate. The difference between B and C is in their Km, right? Because that's what this bottom axis is about. Moving to the left on the x-axis makes the Km lower and tells you that the affinity is higher. So you would not need more B6. But in our case, affinity of the enzyme for B6 is really low. Right, that's basically why he has homocystinuria. So, which is why we need a ton of B6. We need to give this guy a lot of B6, and then his fibroblasts have more cystathionine synthase activity. Right, so the only way we can pick affinity, because that's what KM is about, is we're looking for one that doesn't have a good affinity at all, and that would be this one right here. Right, so that's just your B. Arriving to this answer choice was intimidating for multiple reasons. One, because you might have freaked out when you saw all these lines, and two, because you might not have actually studied enough KM and Vmax, and there could even be a third reason: you didn't practice enough questions with KM and Vmax in it. Right, so you have to be ready to be able to interpret stuff like this on step 1, because you're without a doubt going to get at least 2 questions on your entire step 1, at least 2 questions regarding pharmacology of KM and Vmax. Alright, so choice B has a negative 1 over Km value much closer to 0, which means Km is lower and affinity of the enzyme for its substrate is super low. This makes sense, as giving higher amounts of the competitive substrate B6 is helping. Okay, so you gotta make sure that you are able to make this kind of decision making and analysis on the real test. Now here, number 46, a 52-year-old man is brought to the emergency department 30 minutes after the sudden onset of substernal chest pain. The pain has persisted despite self-administration of 3 doses of sublingual nitroglycerin. So even after taking nitroglycerin, he's still having pain. Okay. His pulse is 90 per minute, blood pressure is pretty normal, physical exam shows diaphoresis, the lungs are cleared auscultation. Alright, so lungs being clear means that he's not having heart failure, where blood is backing up into the lungs. Cardiac exam shows an S4, and you have to remember what S4 is all about. An ECG shows ST segment elevation in the inferior leads, so that sounds like a MI. IV morphine is administered, and he develops generalized pruritus and warmth 1 minute later. His pulse now is super high, 120, and blood pressure is very low. Physical exam shows facial flushing. Which of the following substances is the most likely cause of the new symptoms? Right? So he was just given morphine, right? And now he has all this like flushing and warmth and pruritus. What substance can cause such a thing? You look at all your answer choices. The only one that you know has this kind of almost allergic type of reaction kind of thing going on would be histamine, right? Morphine is a mu-opioid full agonist. One adverse effect of opioids is mast cell degranulation, which is IgE independent. Release of histamine is akin to an anaphylactic reaction, which causes the pruritus, the warmth, and everything else with the facial flushing and all of that stuff that you're seeing in this patient. It couldn't be epinephrine. Epinephrine would be more along the sides of what you would give to fix this, if anything. Definitely not nitric oxide. That's just a vasodilator. Serotonin is more of a CNS hormone, the happy hormone. And thromboxane A2 is a whole different set of things we're not really looking at. This question about whether or not there's a specific order to take NBMEs, everyone has their own thing that they talk about. People say stuff. And that's their personal thing. There is no solid order of taking NBMEs per se. Just take them. That's all that really matters. There's no order. The order thing that people say is just their own theory because they see questions and they were like, oh, NBME 20 was easier because it had X, Y, and Z. Take that last. NBME 18 was really hard because it had topics A, B, and C. Take that first, whatever. But what's easier or what's hard is different for all of us because it really depends on what you studied more, right? So for me, for example, all math type, KM, VMAX, pharmacology, whatever, any graph type of question, super easy. But that's because I was a math major. Whereas for many others, that might be very difficult to even comprehend after explanations. So point is, there's no order, right? If you want to review them, because NBME doesn't give you explanations, you could do the NBMEs I have explanations for, and then come back and watch the explanation video before you even get your results. You don't need to wait, and then just start seeing what's happening. Alright, number 47. A 24-year-old woman with sickle cell disease comes to the physician because of malaise and generalized fatigue for 1 week. She had previously felt well since her last sickle cell crisis more than 1 year ago. Alright, so we're talking about sickle cell patient. She has had no pain. Physical exam shows no abnormalities. Baseline hematocrit is usually 25 to 30%. And that's not so good either. Lab studies now show a hematocrit of 13%, which is even worse. Mean corpuscular volume of 105. Reticulocyte count of less than 1%. She's not making new reticulocytes, which also sucks. Which of the following diagnostic tests is most likely to explain this patient's symptoms and decreased hematocrit? Right? So 24-year-old with sickle cell. Anytime you have sickle cell, you want to start thinking of the fact that these are patients who are, one, potentially asplenic, right, because you have autosplenectomy, and then two, because of the asplenic aspect of things, getting infection from certain specific things that target people who are either asplenic or sickle cell patients, right? And when you go through your answer choices, a Coombs test would be for antibody-related stuff, and that's not kind of what we're looking for here. Hemoglobin electrophoresis would be completely unnecessary. We already know about her hemoglobin. She has sickle cell. Measurement of serum haptoglobin concentration, where haptoglobin would be, pretty much lower, if anything. Haptoglobin's job is to kind of just grab free-floating hemoglobin, right? and there might be some hemolysis going on in this patient, so then there would be no free haptoglobin. Haptoglobin is going to grab all the free-floating hemoglobin, and your free haptoglobin count would go down. Parvovirus is very much possible for her. And then bone marrow biopsy with examination of iron stores would be for a whole different disease, right? That would be more towards like maybe hemochromatosis or something. Not her problem. Her problem is not related to iron, and that's very obvious. So serum parvovirus B19 IgM antibody test would be the perfect thing to do here. Healthy people who get sick with parvovirus may have subclinical illness with arthralgias as the only symptom, but sickle cell patients and patients with decreased hematopoiesis will develop bone marrow failure. All right, let's fix this. And then that's later on known as the aplastic anemia, bone marrow failure, because the virus affects the hematopoietic stem cells, leading to aplastic crises and inability for the bone marrow to adequately compensate, hence the low reticulocyte count. And that was kind of the giveaway, right? Whatever started happening to her was no longer due to sickle cell. Sickle cell already did its thing. She has the anemia. Now she also has a low reticulocyte count. That's a whole different thing. Parvovirus causes slap cheek in kids, hydrus fatalis in the fetus, and aplastic crises in sickle cell and arthralgias in other patients. Right, so this virus is able to cause different kinds of issues in different people. Alright, so that's a very simple and straightforward question for the most part. I wouldn't see there should be any kind of confusion with that question. Biliary structures. Okay, so number 48, 45-year-old woman comes to the emergency department because of a 1-week history of severe abdominal pain. Alright, so we have abdominal pain, history of gallstones, right? She is over 40. So when you think of gallstones, you want to remember that 40, fertile, whatever that little mnemonic was for that. Current medications are atorvastatin, hydrochlorothiazide. Temperature is 99, pulse is 70, respiration is at 20, blood pressure is slightly high, nothing significant. Abdominal exam shows tenderness to palpation. Serum studies show increased activities of amylase and lipase, increased activities of both, going along the lines of like pancreatitis, right? CT scan of the abdomen shows enlargement of the pancreas and dilation of the pancreatic ducts. So enlargement of the pancreas would generally just mean like inflammation of the pancreas, which also goes along the lines of pancreatitis, right? Because pancreatic like edema of the pancreas a little bit, so it's getting bigger. And dilation of the pancreatic duct would mean that something's backing up, right? So something's stuck at the end of the duct, so stuff is making it wide. The most likely underlying cause of these findings is a gallstone lodged in which of the following locations? So we just said it, something's stuck right at the end of the duct and things are not passing anymore, so the duct gets big. Which duct are we talking about? And that would have to be what they intelligently named it in a bullshit way, right? The hepatopancreatic ampulla. This is just the ampulla of Vader. That's the answer. That's the only answer you could pick because they told you what's dilated, right? Remember, things dilate proximal to where the issue is. So let's take a look at what the issue is. Let's go to biliary structures here, right? So you can see you have your cystic duct, which is the one that's bringing stuff from the gallbladder. Cystic duct combines with the common bile duct, which also cystic duct gives you the common bile duct by combining with the common hepatic duct, right? So at this point in the common bile duct, you have bile that came from both the liver and the gallbladder. This common bile duct then goes down to connect here with the ampulla of Vader, right? Ampulla of Vader is right here. And all of that empties in through the sphincter of Oddi into the descending part or the second part of the duodenum when you have food that needs to be digested. Okay, so they told you that this stuff here is kind of dilating in the question. Right, dilation of the pancreatic duct. Right, so what's dilating then? Where's my pencil? So what's dilating are all of these pancreatic ducts. They're saying that these things are getting real thick now. Right, imagine it got as thick as my thing right here. So if the duct gets thick, then of course the bladder itself, not the bladder, what am I saying? The pancreas itself or the gland itself will also start enlarging because the duct inside is getting big, so the whole thing gets big, right? And why is this getting big? Because something is stuck right here, right here. So she must have had a stone that came out, went down, got stuck here at the X because the sphincter of Oddi is pretty tiny. It's not made to let out big stones, right? So gallstones are a big problem because of such things, especially in females, And there are many things that worsen that, right? Hemolysis, cholesterol, being on oral contraceptives, all kinds of things can worsen that, right? So ampulla of Vater was they just intelligently renamed as hepatopancreatic ampulla, right? The other answer choice here that was a trick answer choice was the second part of the duodenum, right? But they're saying the gallstone is lodged. It is lodged in the second part of the duodenum. That is correct. This is the second part of the duodenum. However, the better answer choice was the actual duct. Because it's not lodged, like by saying second part of the duodenum, well, it could be right here too. Is that the problem? And it's not. That's not the problem, right? The second part of the duodenum is a bigger thing. The more specific answer here is ampulla of Vater. So, not too bad. 49. A 9-year-old boy has mild mental retardation and a 4-year history of increasingly frequent major motor seizures. So we have a 9-year-old motor seizures, okay? Physical exam shows normal vital signs, clear lungs, a moderate systolic ejection murmur, and discrete pink to yellow papules in a butterfly distribution on the bridge of his nose, the malar prominences, and along his nasolabial folds. Right, so you've got some kind of weird, what they're describing as a butterfly rash, but you should be careful, right, because we're not talking about lupus with this kid at all, for sure. This is not about lupus. Right, so, but a bunch of things are wrong, right? A moderate systolic ejection murmur, pink to yellow papules in a butterfly distribution, and all over the other places, right? So it's not even just a rash, actually. They're talking about papules, right? So that kind of helps. It's a very common thing to do. What I just did right now is that you read something, but you replace the word with something else that you're used to hearing. Be very careful with that, right? So they put the butterfly distribution, but we're talking about papules. A CT scan shows multiple, occasionally calcified nodules on the crests of some gyri in the subependymal regions, and that should be a giveaway for what the answer is right there. Echo shows left ventricular hypertrophy associated with marked narrowing of the aortic valvular outflow tract due to a subvalvular mass arising from the septum. Which of the following is the most likely diagnosis of the cardiac lesion? So what's his diagnosis overall is the real question, all right? So the constellation of symptoms sounds like tuberous sclerosis, and you have to know your neurocutaneous disorders as well as your various brain tumors, the childhood ones and the adult ones, very well. Like, you have to know everything very well for the most part. But the main point of very well is that you have to know these things in such a way that you should be able to list it out and tell me about them without looking at the book. Right here, this 9-year-old boy's constellation of symptoms is totally tuberous sclerosis. There's everything here is telling you that. And cardiac rhabdomyoma is a rare benign tumor that is frequently associated with tuberous sclerosis. Tuberous sclerosis has subependymal giant cell astrocytomas as well as ungual fibromas under the nail. So let's take a look at this real quick. 569. So right here, right, neurocutaneous disorders. You need to know these very, very well. Sturge-Weber, tuberous sclerosis, of course, NF1 and NF2. These two you should already know super well, so it doesn't even count over here. But the main ones, right, Sturge-Weber, tuberous sclerosis, and VHL, you need to know. Right, NF1 and NF2 should be like common knowledge for medical students at some point, right? So it's no longer a thing you really need to study per se. So our guy had this stuff, right? Tuberous sclerosis with the TSC1 mutation and the TSC2 mutation. Either one of these things can occur, and being a tumor suppressor, right? Being a tumor suppressor, this follows the 2-hit rule, right? Both tumor suppressor genes have to die. Both copies of the tumor suppressor gene have to die for you to start getting cancer. And once that occurs, these guys can start getting all of these things, tumors everywhere. So in our question, specifically, we had the seizures, right? The person had look at this stuff, right? This is the butterfly papules they're talking about, okay? So that's your C, angiofibromas, which you also see in Men 1, keep that in mind. So they gave us those two things. They also told us some level of mitral regurgitation, right? And then the answer for us was the cardiac rhabdomyoma. Right? What they didn't give were the shagreen patches that look like this, and the ash leaf spots, which looks like image D. Right? They didn't give those two things, and then of course they did mention a subependymal giant cell astrocytoma in the brain, and they can often ask you what else you would find, so you would pick ungual fibroma as another thing. Right? There's a bunch of things happening here. The hamartomas mnemonic is pretty decent. I don't really tend to use it much. It never really helped me because I could never remember what all of these words stood for. But I would remember the angiofibromas, I would remember the mitral regurgitation, and the angiomyolipoma, renal. This was because I had a question on that once, right? This one right here, right? So this full list of everything from C, D, E, these images. If you can memorize them, then you remember this. One thing I always tell people when you're doing UWorld questions, preparing for step 1, is to always come back to UWorld. Sorry, come back to first aid, right? When you're doing UWorld questions, always come back to first aid. The more times you return to this page, the more times you get to look at the images and what the differentials are, right? And then you'll have a better and better memory every time you come back. So every time you do come back to this page, because maybe you had a question on VHL, or Sturge-Weber, or Tuberous, or any of these things on this page, you should also look at the images and tell yourself, A and B, these two guys are your first thing here, Sturge-Weber, right? Where you have your cranial nerve V2 area of marking on the face, right? You have these kinds of calcifications or whatever in the brain, and a bunch of other stuff, right? This thing, you have your CNV1, V2 distribution of what they call as a port wine stain, but it's really a nevus flammeus, and you have to remember that from Master Choices if you ever see it. And then this, I have another image here for it too. This is a very common thing you want to watch out for, right? The tram track calcifications of opposing gyri, right? Tram track. So this is a very common thing. Of course, you might get a really young kid that presents with some level of elevated intraocular pressure because of episcleral hemangiomas, early onset glaucoma, and then you have to go on and make the diagnosis based off of whatever else is in the question. Good page, a lot of stuff to know here. Just master it. Memorize this entire page and then be able to talk about it without having to really open that page. It's not so hard. It will take some time though. A 48-year-old man comes to the physician because of increasing bronzing of his skin, weakness, and fatigue during the past 3 months. Physical exam shows bronzing of the skin, hepatomegaly, and small testes, right? Serum studies show all of these things are high. Ferritin, transferrin saturation, iron, right? Liver enzymes, and then testosterone is low, LH and FSH are low. Which of the following best explains the findings? Well, this is very obvious, right? They straight up gave it to you. Iron is high, and you have elevated liver enzymes and hepatomegaly. So you look at your answer choices, and you must have increased intestinal iron absorption, which is part of hemochromatosis. The patient has bronze diabetes symptoms in this question. Right, so let's take a look at hemochromatosis real quick. Hemochromatosis questions are almost always very straightforward and easy. Right, so in hemochromatosis, there's a thing called bronze diabetes. Right, you get skin pigmentation, diabetes, and cirrhosis, which they told you based off of the elevated liver enzymes. Maybe the patient hadn't gotten to the point of cirrhosis yet, but eventually will. And there really wasn't anything else to that question. Pretty straightforward. They gave you enough stuff. Keep in mind that classically with hemochromatosis, you get restricted cardiomyopathy. But for step 1, you're probably going to get dilated cardiomyopathy. Mainly because hemochromatosis is not part of the ABCCCD mnemonic of memorizing all the things that cause dilated cardiomyopathy. Even pregnancy is one of the things that can cause dilated cardiomyopathy. Very important thing to make sure you have full mastery of, right? Whenever you study cardiovascular, that's a chapter that takes a lot of days and a lot of time, and you have to make sure you stop and give ample amounts of time to this page, right? Where you memorize the ABCCD stuff, sure, that part is easy. Then you have hemochromatosis, cardiac sarcoidosis, thyrotoxicosis for obvious reasons, and then look, peripartum cardiomyopathy. Right, there was a question on this somewhere too. I think it was an NBME. I can't remember for sure. Where a mother had just given birth, and they say that to you in the sentence in the question stem like it's no big deal. Right, then they go on to tell you that a lot of cardiac issues are popping up, and those cardiac issues sound a lot like dilated cardiomyopathy. But then you're just like, why would I pick that? There's no reason to, unless you remember that peripartum cardiomyopathy does include, or is one of the things that can lead to dilated cardiomyopathy. Right, so you have to be ready with that. Very important stuff. The other answer choices also just didn't fit. Like, none of those are relevant to the way this patient is presenting. Okay, 51. A 35-year-old woman comes to a physician because of a 2-day history of blistering lesions on the sun-exposed areas of her face, arms, and hands. She has had recurrent episodes of these skin lesions for several years. She's been taking a combined oral contraceptive for 15 years. Physical exam shows fluid-filled vesicles and bullae on the face and upper extremities. Lab studies show elevated liver enzymes, high total porphyrin, high urine uroporphyrin 3, okay. Deficiency of which of the following enzymes is the most likely cause of this patient's porphyria, right? We know this is a porphyria because they gave you the elevated total porphyrin. Now, the only way to pick the correct answer was figure out the symptoms and then remember, of course, right? Now, this patient does have some level of photosensitivity, right? Blistering lesions in the sun-exposed areas. You look at your answer choices, and the one you always pick when you see that is C. How do you memorize your porphyria? So we did this when we did Hemoc, right? Everything has an easy way of memorizing and then retaining. Even the congenital adrenal hyperplasias or whatever it might be, there's an easy way to memorize and master each thing. So the day you're mastering this, you look at it, right? Lead poisoning was the first thing you've already learned in other parts of the book. You've already got that down. So we don't really need to talk about lead poisoning, but if anything, it's got the furochelatase and aldehyde enzymes involved, right? So furochelatase and aldehyde, you have to remember where they are as well. And as far as we care, it's right here for this one, right? The one inside, the aldehyde. This is the second enzyme. The first enzyme is always obviously synthase, the one that synthesizes your aminolevulinic acid. Then dehydratase is the one that breaks it into porphobilinogen, which is what's going to get worked on. And the second one is outside, furochelatase. This is the one that chelates iron into heme. Very easy name to remember. Right, furochelatase. So those two for lead poisoning. One that's inside the mitochondria, furochelatase, and then the other one that's outside. So they could have both answer choices in a question about lead poisoning, but they might ask you for the one that's in the cytoplasm, for example. So you have to remember to pick aldehyde. Okay, that's easy. Now, the two that you have to memorize separately, AIP or PCT, right? Acute intermittent porphyria or porphyria cutanea tarda. Now, of course, porphyria cutanea, about the skin, this is the one that's more so related to photosensitivity. The other one, AIP, is the one that's related to every other P besides photosensitivity. So painful abdomen, port wine urine, polyneuropathy, psychological disturbance, and precipitation due to either drugs, alcohol, or starvation. Right? Like someone that might be stuck in a cave, starving due to some kind of homelessness, whatever it might be, right? So those are other scenarios you can get questions on. Now, our patient has PCT. So for this is not the one that you memorize all the P's for. PCT is just photosensitivity. This is the one you memorize all the C's for. So decarboxylase, cutaneous, and hep C. Right? This is always or often associated with hepatitis C. This is also the most common porphyria. Right? So another C word would be common. So you have to use that. You have to play with that and then memorize it, because this is how you will be tackling these things. Now, alcohol is part of both. So you can see how alcohol can precipitate AIP and can exacerbate PCT. So you have to be careful with, what the symptoms are if the question is using alcohol as one of the concepts. All right, so you have to look at the symptoms. And PCT is the one that's cutaneous, photosensitivity. AIP does not have it. You're going to have some kind of weird urine, pain, polyneuropathy, a bunch of issues in that patient. Whereas our patient simply came because of blistering lesions and no other major issue. Nothing else. Just blistering lesions. That's where her fluid-filled vesicles are. Her fluid-filled vesicles are the, when you, like, maybe if you touch something real hot by mistake and then you get like a weird fluid-filled vesicle and you really want to pop it, something like that. Just photosensitivity. Very easy. So you have to remember the name of the enzyme with the C, decarboxylase. It's the carboxylase enzyme. Because you know you're talking about PCT, Porphyria cutanea tarda. If you're ever talking about the other one, AIP, that's the one with all the P's, and even the enzyme name is just P's, either porphobilinogen deaminase, that's the one you want to look for. It was previously known as this, but this should not be getting used as an answer anymore. Right? So it's just another P, porphobilinogen deaminase, right? And they have that, answer choice A, porphobilinogen deaminase. Protoporphyrinogen oxidase is such a impossible, like there's probably never been a time in your life you ever said that. It's not even here. It is one of the enzymes, but it's not one that's significant. It's not significant at all, the oxidase one. Okay, this one was a very conceptual thing. 65-year-old woman comes to the emergency department because of a 4-hour history of vomiting bright red blood. She also has had dizziness and nausea during this period. Her pulse is 140 per minute, which is very high. Blood pressure is very low. So that's got some kind of like, almost some sort of maybe shock or something going on. These are NBME questions. Physical exam shows pale, clammy skin, diaphoresis, and decreased capillary refill time, all of which has to tell you more about the fact that this is some level of shock. And then they go on and tell you that a diagnosis of hypovolemic shock is made. Placement of a catheter in the internal jugular vein for blood transfusion is planned. Improper insertion of the catheter is most likely to result in damage to which of the following sets of underlying structures? Right? What are you going to end up messing up if you're a brand new nurse that wasn't trained well enough and you insert the catheter into the wrong thing? What are you going to hurt? So look at all your answer choices, right? Common carotid artery and pulmonary artery. Well, first of all, pulmonary artery, that's really far deep behind the heart and whatnot. That's not going to be the answer choice. So A is wrong. B, esophagus and common carotid artery. Your esophagus is much more central, right, than the jugular vein. It's very, very unlikely that you're going to hit the esophagus. So that's out of the question too. C has esophagus again and pulmonary artery again. And we've already debunked both things. So those guys are out of the question too. Lung and common carotid artery. Well, the lung is huge, right? It comes all the way up to here. Very big. So the lung is possible, right? Because the thing we're trying to get into, your internal jugular vein, lies over the lung. So, of course, that's possible. Common carotid artery is also in that area. So that's also possible. And then again, answer choice E has esophagus in it. We've already debunked the esophagus. Can't be the esophagus, right? One of the ways to tackle this question would have been to see the fact that esophagus is in 3 answer choices and figure out if esophagus is even possible. If it is possible, then you're picking between one of those 3 answer choices. And if it's not, then you're picking between the other 2 answer choices. And the esophagus for our guy is not going to be possible. Right? The esophagus is retroperitoneal. That's another very important fact to remember. Right? And the jugular veins are far from retroperitoneal. They're not. The IVC is, but not the jugular veins. After that, the lung starts to make much more sense, right? Because you are between, for the other 2 answer choices, you're either between lung and common carotid, or this one, common carotid and pulmonary artery. And pulmonary artery would be somewhere over here, right? Working with the heart, so you're not gonna go for that. All right, 53 is a men's syndrome question. 38-year-old woman comes to the physician because of a 10-week history of epigastric pain and frequent stools, right, for 10 weeks. She has had 2 episodes of renal calculi during the past 2 years. She's getting chronic renal stones, which makes you think that she might have hyperparathyroidism, and those are probably calcium stones. Physical exam shows multiple superficial lipomata and mild epigastric tenderness. Now, lipomas are a giveaway for men 1, okay? In the presence of multiple other issues, of course, not just alone. Upper endoscopy shows 2 large non-bleeding duodenal ulcers, okay? Gastric pH is 2.3, which is pretty acidic. So gastrin concentration obtained immediately after the procedure is very high. Right, so she's got a couple cancers going on. PPI therapy has begun. Measurement of which of the following is the most appropriate next step. So right now, immediately, we need to find out if she has MEN1. Because if she does, then we need to start putting her through many other procedures where we prevent issues from any of the other MEN1 related syndromes. And here, answer choice A was the only thing that was relevant. Serum calcium concentration. Yeah, exactly. Yeah, for the lung thing, that question was not so bad. But again, questions like that catch people off guard because they probably have not gotten the experience of such a question before, and they have nothing to reference to. But you don't always need that experience. Just think clearly. So this is MEN1 right here, right? So pancreatic endocrine tumors, which includes your Zollinger-Ellison syndrome. That's why that patient's gastrin was so high, right? It includes your insulinomas, VIPomas, and gluconomas, which our patient probably didn't have. There was the presence of the lipomas in our patient, and of course, most likely has a parathyroid adenoma as well, right? Many things here, though. You also have angiofibromas, collagenomas, and meningiomas, right? Many issues in MEN1, right? MEN2A at least, has parathyroid hyperplasia. We got this parafollicular medullary thyroid carcinoma, right? And then FEOs, which secretes catecholamine. So that's where the other answer choice is, right? Checking for serum cortisol. What is it? And the urine 5-HIAA concentration. All of these other things, very much irrelevant to MEN1, right? It's not relevant to MEN1. And then lastly, of course, MEN2B, that's the one that is special for mucosal neuromas, mucosal oral or intestinal ganglioneuromatosis. Right? So not the worst thing on earth, but it takes some time also. In the beginning, I used to really despise MEN syndrome questions because it was pretty hard. The questions would start off with something completely weird and then start talking about many other things. And if you've never really practiced MEN syndrome questions, you'd be lost. Once you're done practicing and studying, though, it should not be a difficult decision at all to pick the right answer for such questions. 54, a 32-year-old woman comes to the emergency department because of fever, intense headaches, excruciating pains in the joints and muscles of the arms and legs that began 4 days ago when she returned from a Caribbean cruise. During the trip, she visited Cancun and the Yucatan region. Her temperature is super high, respirations at 32 per minute, blood pressure is 130/80. Physical exam shows a mild macular rash over the trunk. The remainder of the examination shows no abnormalities. Which of the following is the most likely route of transmission of the causal organism? So intense headaches, fever, excruciating pain in the joints and muscles, right? And then the rash, where is it? And the mild macular rash over the trunk, right, over the back. So whatever's happening to this patient, it really looks like it's something that's gotten, if you come from a country or experiences where people got mosquito bites and then ended up having something malaria type, or even if you were in India and you've experienced family members or relatives of some sort who had to go through fighting dengue, you know this answer immediately because this is what it looks like, right? This is what it looks like. This is going to be a patient who just came out of nowhere, started talking about some kind of, insect thing must have happened where they picked up a disease and now they have all of this fever, headaches, pain everywhere. The whole body hurts out of nowhere, right? So although it's unclear, people argue this could be dengue or Zika. Regardless, the vector is the same for both of them. Dengue, breakbone fever, and Zika arthralgias are all good giveaways for this stem, right? So the answer had to be an arthropod vector. This definitely was not due to a blood transfusion. That would not cause all of this, all right? Contact with respiratory secretions would usually lead to another cold or something. The latest thing right now is the coronavirus, right, which could be from respiratory secretions. Fecal oral was irrelevant for this. Maternal fetal was definitely irrelevant for this. Sexual contact was irrelevant for this. Small airborne droplets or respiratory secretions both kind of fall for more like the same kind of stuff, right? Not happening. So the other answer choices were very much out of the place. You would really just be stuck between arthropod vector or fecal oral. Did she ingest or eat something weird or something like that, right? But it wasn't anything more than just getting the wrong mosquito bite for that day and ruining your trip. Trips often get ruined because of mosquito bites. It just happens. 55, a 59-year-old man comes to the physician because of a 3-month history of progressive difficulty swallowing. He's had a 15-pound weight loss during this period. He's smoked 1 pack of cigarettes daily for 40 years and consumes 4 to 6 beers daily. He is cachectic. Bilateral wheezes are heard on auscultation of the chest. A chest x-ray shows enlargement of the paratracheal and hilar lymph nodes. Subsequent endoscopy shows a 6 centimeter mass in the mid-esophagus. The mass is centrally ulcerated with an elevation of the surrounding mucosal rim. Right, so we're talking about something that looks like this. Right, so they're trying to describe it to you without showing it to you. So you have some kind of ulcer with the central rim. Right, so something in the middle is missing. What did they say? Mass is ulcerated. Right, so the ulcer is in the middle with an elevation of the surrounding mucosa. Right, so there's going to be elevation. The rest of this thing is like elevated beyond this, right? And you're seeing this in the esophagus somewhere. So you know when you see something really fucked up like this, that's cancer, right? Examination of the biopsy specimen of the mass is most likely to show neoplastic cells with which of the following. Right, so what kind of cancer do you get in the esophagus? Now, did they tell you how far? Mid-esophagus, right? Mid-esophagus. So very important thing, because in your entire esophagus, from up to down, you kind of want to divide that into the first 1/3 and the latter 2/3, and then who gets which one is really also based off of epidemiology, what kind of person you are, where you live, because that kind of determines what you've been eating and drinking. For our guy, looking at all your answer choices, you would pick B, keratinization, right? Why would you pick that? So let's take a look at what's happening. 409. Why would you pick keratinization? So this guy had esophageal cancer, right? Now, oh, did I do it the wrong way? My bad. Let's undo that part. No. It's the upper 2/3. Sorry. Totally forgot that part. So upper 2/3 and the latter 1/3. The final part before it finally enters the stomach, right? So, ooh, no. Right here. So before it finally enters the stomach, because then once it enters the stomach, that's a whole different thing right now. Right? So what's special about this region here, and what's special about this region here, and where do things get affected? We know about the bottom 1/3 part, right? This is where you have acid reflux. So acid comes back up, causes damage, and you get metaplasia and barred esophagus, blah blah. You get cancer down there. Up here, damage usually occurs from drinking hot liquids or alcohol, right? And that's what they're kind of explaining to you in this portion right here. The most common thing worldwide are the upper 2/3 squamous cell carcinoma. Upper 2/3 encompasses the midway part also, right? 50% is within the 66% range. Alcohol, hot liquids, and smoking, achalasia, all of these things cause it. So this is most common worldwide. In America itself, though, because of the commonness of obesity, chronic GERD, and smoking together, adenocarcinoma in the lower 1/3 is more common in America. Now, our guy, right, did he emigrate? Let me see. No, he didn't emigrate, right? So you're thinking this is a guy in America. However, right, the way that they termed the question and everything they put into it, because this is the mid-esophagus, not the lower end of the esophagus, you're going to go with squamous cell carcinoma. And there's a description for both of them that's different from each other. Squamous cell carcinoma has solid nests of neoplastic squamous cells with abundant areas of keratinization. All right. Adenocarcinoma is the one with elongated papillae, intraepithelial eosinophils, and basal cell hypertrophy, and they both look very different from each other. Right, so this left image here is showing you squamous cell carcinoma. These are your keratin pearls. The right image here is showing you your adenocarcinoma with the papillary, right? Papillary means finger-like projections, right? So these are finger-like projections right here. All right, so very important to be able to differentiate between the two kinds of things from each other. Based off of the location of the tumor itself, as well as the epidemiology of the patient. Where is the patient? What kind of patient is he? And what's his weight? What's his lifestyle, etc. Stuff like that. Other than that, there really isn't any other way to pick. Okay, and did they have an answer for both things? And they didn't have an answer for both things. They didn't have the papillary projections and whatnot either. So you would just pick the full guide keratinization and that'd be it. Let me just get rid of this real quick. Alright, let's keep going. 56. So a 55-year-old woman is brought to the emergency department by police 1 hour after she was found wandering around the city park at midnight, appearing confused. She told the police that she is a prominent physician and a member of the city council. She is unwashed, malodorous, and disheveled. 5 feet 3, weighs 55 kilograms, BMI is 21, pulse is 82, blood pressure is fine. Physical exam shows a broad-based gait and nystagmus, which is kind of a giveaway of what's happening to her. She's not oriented to person, place, or time, but she is pleasant and cooperative. Results of alcohol and drug screening are negative. An MRI of the brain is likely to show atrophy of which of the following, right? Now, this question was kind of unfair because there was no reason to say results of alcohol and drug screening are negative. I'm very much positive this patient's result of alcohol screening would not be negative, all right? I'm sure her breath even smells like alcohol because she is an alcoholic. The reason this patient is presenting the way she is because of Wernicke-Korsakoff syndrome. And the only answers you could pick here would be D, mammillary bodies. None of the other major things that can present in such a way would actually have effect on any of these parts of the brain. So once you saw these answer choices, you should have been like, all right, the only answer choice I can pick must be the mammillary bodies because nothing else ever gets damaged in such a patient like this, a patient that presents in this kind of manner, right? This is a drunkard. This is an alcoholic person, right? Smelly, unwashed, confused, broad-based gait, nystagmus. So what else have you seen an alcoholic ever look like? It's a person that's walking all shaky. They look really, really nasty. They haven't showered in days. It's an alcoholic person. That's it, all right? The reason why they said results of alcohol and drug screening are negative is because she might be a chronic alcoholic, but again, I don't agree with that, right? Of course she's a chronic alcoholic, but why would results of alcohol screening be negative? Why would you even do an alcohol screening? She probably smells like alcohol regardless, right? So very important to make sure that you're able to not, let something like this throw you off. It's a very NBME kind of thing to do. I don't think step 1 would give you this sentence, results of alcohol screening are negative. No, they would have given you the results of drug screening are negative, not alcohol and drug screening. No. But I did try explaining it. I wrote she probably hasn't drank recently to have a positive screening, but, she's still a chronic alcoholic, so everything else is damaged. So I can see how you could have a negative screening, but why would you do that? Like, if they smell like alcohol, their breath smells like alcohol, it's an alcoholic, whatever. She didn't just have a drink recently, that's all. But she hasn't hit alcohol withdrawal symptoms yet, I guess. This one, 57. A 16-year-old boy is brought to the physician because of a 3-month history of shortness of breath while playing sports. He has no shortness of breath at rest. He says, whenever I run around, I cough, so I don't want to be on the basketball team anymore. He takes no medications, has no allergies, family history of hypertension and asthma. He is 5 feet 5, 68 kilograms, BMI is okay. Respirations are slow, 12 per minute. Blood pressure is normal. Cardiac exam shows nothing wrong except for a mid-systolic click at the apex. Lungs are cleared, auscultation. Which of the following best explains his symptoms? So you look at all the answer choices, and the only thing you could pick is exactly what he said. He said every time he runs, he starts coughing and has shortness of breath. Exercise-induced asthma. Many students chose D, mitral valve prolapse, because they mentioned a mid-systolic click at the apex. Many students chose D, but this patient's main symptom is cough only during exercise. This is more indicative of exercise-associated asthma. You could see a shortness of breath in MVP during exercise, but choosing MVP leaves the cough unaccounted for, right? You could have shortness of breath in a patient with mitral valve prolapse also, especially during exercise, sure. But then why would the person be coughing? Right, so the coughing part is the asthma part, the choking up aspect of things. Again, messed up concept, messed up question. I wouldn't really say this is fair per se. But it is what it is, right? And also pay attention to the order that information is always given in. almost all step 1 questions start with an order of importance. They'll tell you important things, then they'll start telling you not so important things that are there to really just confuse you into not picking the right answer choice. Because the important parts are going to make you think, and just like the first few sentences of this question, the important parts of the question are going to make you think of the correct answer, which is B, exercise-induced asthma. Then the latter half of a question is going to try to throw you off towards the wrong answer choice, which is the last 2 sentences, right? Cardiac exam, mitral mid-systolic click at the apex. Not exactly the biggest deal. Not exactly the biggest deal. So, mitral valve prolapse wouldn't be this 16-year-old student's issue here. 58. Diastolic blood pressures are obtained in 2 groups of 100 asymptomatic men, group X and group Y, right? So you have group number and then diastolic blood pressures. Okay. Results are shown in the table below. So there's 8 people, and 8 people in group X had this diastolic blood pressure, and 2 people in group Y had this diastolic blood pressure. Right? So you want to make sure you understand how to interpret the results before you read the question. Then you read the question: compared with group X, which of the following best represents the median and mode of group Y? Right. So if I was to put all the numbers from in increasing order, what will be the middle diastolic blood pressure? And then the mode, which is the blood pressure that's most common. Compared with group X, which of the following best represents the median and mode of group Y? So even the way they started this sentence was kind of messed up, but they just want you to answer any, that one question about median and mode, the difference between them, and then they have a bunch of answer choices. Now, your mind might explode right there and be like, how am I supposed to do this? Especially if you're running out of time, right? Because then you're like, this is going to take a lot of time. But it doesn't. It doesn't take a lot of time. First things first, always just calm down and just start solving it systematically. Right, so group X, let's do them first. So what's going to be the median? Right, what's going to be the median of group X and what's going to be the mode of group X? Right, so let's do that first. So then you look at group X. Okay, the most common one is this right here. Right, that's the most common. So mode is going to be most likely around 70. And median, well, if I put all the numbers in order from left to right into increasing order, 8 and 12 is 20, and then over here we have 30, 40, 48. So something between 70 and 80 would probably be the median. So maybe 75, something like that. Okay. Then you look at Y. Look at Y now. So in group Y, the most common one, because that's what the mode is, whichever one was most common, the most common one was right here. Right? 20 people had a 80 diastolic blood pressure. Now, mode is very secure, right? We figured it out for sure, and we know for sure that Y has a higher mode than X does. So mode of group Y will be higher, higher, or higher. Look, we're already down to 3 answer choices. This just became a lot easier at this point. We can guess right now. If we only have 10 seconds left, pick one of these 3, move on. And if you just pick A, you're right. If you pick C or F, you're wrong. But whatever, right? I don't really think you're going to pick F because F says the same median, and that's very unlikely, right? So you would pick between lower or higher, and hopefully you'll pick A, but if you pick C, then whatever, you tried. But let's find the median. What will be the median here if we lined all of these numbers in increasing order? Right? So again, you can see though, in group Y, there's something that happened in group Y that didn't happen in group X. The distribution is almost much more even here, right? There's like almost some sort of bell curve kind of thing happening, and it goes all the way to the end, right? Whereas here, everything kind of lined up to right there. Okay, drawing this kind of a graph like I just did is not that hard. Like what did I do? I was just plotting the numbers the way they showed up in increasing order, and it looks like the median for this guy falls more so in this range between 80 and 90. So this is also going to be higher, all right? Between 80 and 90 somewhere. It's really not that hard. It's something that you have to practice, I guess, and just really think about. Think before panicking. That's a pretty good advice right there, right? Think before panicking, because if you panic before you think, then that panic is already going to mess up your thinking process, right? So because they gave you numbers rather than graphs, it was harder to visualize things. But you remember, if you studied, that the bell curve that was given in your book, the bell curve in your book really dictates your median, mode, and mean. The mean of the bell curve was actually the dead smack center of that bell curve. We see that in our book. Let's see, wherever they draw that bell curve. Was it in pharmacology? No, in epi. Right. Yeah, right here. All right, so you can see how mean equals median equals mode with the bell curve, right? And then depending on how the bell curve's tail is, if it's a positive skew, so the tail is at the positive end, or a negative skew where the tail is on the negative end, your mean, median, and mode shifts, right? And there's a reason you draw these bell curves, and this is how the bell curves would look like for these two guys. And you can see that most of the things are mostly centered between 70 to 80 over here for group X, whereas most things are further down between 90 to 100 range for group Y, so both numbers are higher for group Y. End of story. Right, much quicker if you can do that. So that's a good experience to have by watching this question just now. And then hopefully if you do get a question like this, you'll be able to repeat some kind of process similar to that. Got to figure out something, right? Survival of the fittest. Figure something out or perish. 23, so this is question number 59 over here. 55-year-old man comes to the physician because of a 2-month history of fatigue and a 3-day history of nausea and diarrhea. He's had a 12-pound weight loss during the past 2 weeks. Temperature is 100 degrees F, pulse is 110, respiration is 24, blood pressure is low. Physical exam shows dry skin with hyperpigmentation, right, and delayed capillary refill. Serum studies show you high potassium. BU121 glucose very low. Creatinine is showing bad renal function. Which of the following serum hormone concentrations is most likely decreased in this patient? Right. So you look at your answer choices and then you start thinking of what it could be, because here, one answer choice that immediately makes you think of a lot of things is answer choice C, cortisol. Cortisol is a big deal, right? Cushing disease, Cushing syndrome, a bunch of stuff happens with that. One of the key things they gave you in this question was the random hyperpigmentation, right? This is very critical. Why is there hyperpigmentation? So this hyperpigmentation aspect of things should make you think, right, with an endocrine question, again with Cushing and whatnot, that ACTH also has another part to it with the MSH, melanin stimulating hormone, you could think of it like that, that causes hyperpigmentation. So if you're making a lot of ACTH, you're also making MSH at the same time. And you have both things as an answer choice here. Is the issue ACTH or cortisol? Which of the serum hormones is decreased in this patient is what they're asking. I just said you're making a lot of ACTH, right? In Cushing, you're making a lot of ACTH. You're trying to get your adrenal gland to do its job. It's not responding because you're not making, and because of that, you're not making enough cortisol, right? So the answer here was C, but of course they put ACTH as answer choice A to make you fall for it, right? You're going to pick it because you didn't pay attention to the question asking you what is decreased, right? So the STEM is describing primary adrenal insufficiency or Addison's disease, which falls under a subcategory of Cushing type stuff. Cushing in itself is hypercortisol, right? And that can be due to many different reasons. It's a whole different thing over there. After that, your differentials of things that can happen to people are your adrenal insufficiencies. It's all in the same, well, not the same page, but I think they're right next to each other. Those pages are right next to each other. So first thing you talk about is Cushing, and then the thing right after that is adrenal insufficiency, the opposite thing, right? So both of these things are very much related. Here you have excess cortisol stuff, so you get all the symptoms of excess cortisol in Cushing syndrome, and there's a lot of ACTH depending on what kind of Cushing issue you have. And then here in adrenal insufficiency, there's always high ACTH because your adrenal gland isn't responding, right? And I just said all of that the adrenal gland must not be responding, which is why you would have high ACTH, and you're making all this ACTH, so you have the hyperpigmentation, you're done, right? These kinds of questions should not be confusing. Now, the serum studies are here to both help you and intimidate you. You have to memorize that, right? And when we did this, we went through this in I've come back to this page so many times because every time this shows up, I come back and show you guys this, right? Anytime you have a patient with adrenal insufficiency, you want to think of the fact that no aldosterone means that you're going to lose sodium, right? Because aldosterone's job is sodium retention. You're going to lose sodium and you're going to keep the positive potassium and H. Keeping H means acidity, right? Metabolic acidosis. Keeping H also means you must be losing your bicarbonate, right? Because you can't keep both things. They would cancel each other out. Losing bicarb means that you're going to keep chloride via the basolateral bicarbonate chloride exchanger in the PCT of your kidney, right? And this is very critical stuff to memorize because you get questions where all of this might be there and you have to pick up and down arrows, right? And you have to pick chloride too. And of course they'll put chloride there because they want to intimidate you and confuse you. Right? This memorization thing was perfect. When I first started using this, I just started remembering it exactly the way I read it, like from right here. Compare that to the other one, hyperaldosteronism, too much aldosterone. So too much aldosterone means you're going to keep all your sodium. It's the other way around now. Keep all your sodium, lose potassium and hydrogen. Losing hydrogen is alkalosis, and then from there keep going, right? Your aldosterone escape mechanism, which is basically due to ANP, right, will normalize the sodium, but potassium will still be low, and bicarb will still be high, and chloride will be low because of the same basolateral exchange, right? And we see that here, right? This guy's potassium is high, right? They didn't give you a pH, right? They didn't give you a pH, but you can assume that H must be high too, so this is an acidosis patient, and everything just falls into primary adrenal insufficiency. Well, adrenal insufficiency, and most likely primary also. Adrenal gland probably isn't working, which is why he's so weak, right? Dry skin and all of that stuff, because you don't have any aldosterone and you don't have any cortisol. Both things are not being made in adrenal insufficiency. Low cortisol, low aldosterone. Low cortisol is a big deal because when you compare adrenal insufficiency to congenital adrenal hyperplasias or whatever, in the CAHs, cortisol is never low. Cortisol is always going to be pretty much normal or high because you're trying to upregulate the whole thing, right? So cortisol is going to be high, basically, but never low for the CAHs, so you don't mess up that answer choice. All right, so that was 59. Let's just do one more because, yeah, I'm pretty tired too, Nathan. I get it. So let's just do one more and then we'll call it a day for now. Clinical trial is conducted to compare the efficacy of a surgical procedure versus medical management of gastroesophageal reflux disease. In the study, 800 patients are randomly assigned to either the surgical procedure group or the medical management group. Each group consists of 400 people. Of the patients assigned to the surgical procedure group, 75 do not undergo the operation during the study period. Of the patients assigned to the medical management group, 50 undergo the operation during the study period. Okay, in an intention to treat analysis, something that's not discussed in first aid, which of the following most accurately represents how many patients would be analyzed in the surgical procedure and medical management groups respectively? Right now, the cool thing about this is that this analysis is named very intelligently: intention to treat. In intention to treat analysis, you act like everyone did what they were supposed to do, and your intention was a good intention. You were going to treat everyone, so you look at everyone. Answer choice C. Okay, ITT analysis includes every subject who is randomized according to randomized treatment assignment. It ignores non-compliance, any protocol deviations, withdrawal, and anything that happens after randomization. All right, it's very important. So this video here is actually a really, really good video that teaches you not only intention to treat, but also the other two subcategories that go along with intention to treat. There's also other ones. And NBME has been asking questions about this. I think intention to treat analysis was actually in another NBME I also overwent. I reviewed already. So worth investing time into and mastering. Thank you very much for joining right now. This was up to question number 60. In the next video, I'll do 61 to 80. So make sure you subscribe so you get notification when I'm live, and I'll continue this on Thursday now, not tomorrow. Yeah, Thursday now, same time, 6 to 7 p.m. All right. Thank you very much. Take care, guys.